All right, welcome. We are in our Zoom meeting here. Take a little second to look about facts, fiction, fraud, and truth, hope and fear. COVID-19 in Hawaii is certainly a political discussion item. Normally, it would be a thing we'd be getting around the water fountain and talking about, or in the coffee room. We don't have that. I'd like you to take a look at this free Russian vaccination and see if you see the advantage of the various efforts that are being made. If you have questions during the presentation for Justin, Dr. Kerr, I'd like you to use the chat function and write them out and send them to me in the private mode. And then at the time, halfway through the session, we'll have a chance for me to announce what some of these questions are and for Justin to react to them. And then at the end of the session, it'll be an open free-for-all. Raise your hand or make your voice heard, and there'll be an informal dialogue among us. I think the statistics that are important, that it's just 7 months after the first case in the USA, we're already up to 5.5+ million cases and 174,000 deaths. Why?
Bill, is this, are we going to have old business, new business, that kind of stuff?
No.
No.
And this will be an attempt to change that aspect of it. Our board of directors meetings will have that formality.
We are going to have some humor, though, right, Phil?
Absolutely. So we have some puzzling numbers, and that I want everybody to sort of be aware of what Hawaii's circumstances are. Although we've had 219,000 tests, we only have discovered 5,586 cases. One of the things that I think Justin will help us understand is what's the significance of that ratio. So any participants here that aren't that are present as guests, they're not directly from the EAH mailing list, but ask you to use the Zoom's chat function and make a private message to me that will let me know your name and email and any introduction you may wish that we can make to let our members that are here, let you know that you're visiting. Right now, I'd like to switch and come out of and let Mac do a little bit of his humor. Go ahead, Mac.
This is a case of the truth being funnier than fiction. It's a legal case, Charlotte, North Carolina, not too long ago. A lawyer had bought a very expensive and rare box of cigars, and he had them insured for, among other things, fire. So after a month, he had smoked the 24 cigars, and he put in a claim to the insurance company saying they had been lost in a series of small fires. The insurance company refused to pay. He took them to court, and he won. Even the lawyer or even the judge who said this was a frivolous case said, you insured them against fire. You didn't specify, what was an appropriate fire, even though it is the nature of cigars to be smoked. So instead of appealing and the cost of that, the insurance company decided they would just pay, which was $15,000. Now, here's the good part. You remember the shadow. The weed of crime bears bitter fruit. When the lawyer went to cash his check, as soon as he cashed it, the insurance company had him arrested for 14 cases of arson. Crime does not pay.
Okay, thank you.
Yeah, thanks,
agree.
Mac.
Oh,
I'm
great. Good.
going to introduce our speaker for today. It's Dr. Justin Kerr. He's from Talus Analytics, and his office is out in Washington, D.C. He specializes in applying data analysis and modeling and public policy analysis to major challenges in global health. His PhD is from University of Maryland, School of Medicine. So I now turn it over to Justin.
Get my screen shared here. How about that?
Looking good.
Good.
One copy. Good. Perfect. And let me know at any point if you can't hear me. So like Phil said, I'm Justin. It's good to meet you. Thanks for inviting me to talk. I'm a bit of a replacement. I know our CEO at Talus, Ellie Graydon, was originally scheduled and unfortunately had a last minute family change of plans. So glad to be with you in her stead and talk about very much the same projects and work that she would have spoken with you about, the core work we do at Talus, and especially how it has applied as we've been tracking and doing our best to support the COVID-19 response. So we, in addition to being interested in public health, we've worked in emergency response across lots of different contexts, so hurricanes and earthquakes, and obviously disease outbreaks are a little different. So fundamentally, they're much longer. So it's hard to imagine going outside in the middle of a Category 5 hurricane, but when a pandemic goes on for months and years, there's obviously certain parts of society that are not going to shut down that whole time the way you might be able to shut down large segments of things during a hurricane or in the aftermath of an earthquake. So fundamentally, we have to try to shift our mindset to something that operates on a time scale that most things don't for us in our everyday life. So to respond effectively, we really need to sort of understand that kind of context. Try to understand where it is now and where it might spread. So there's certainly some analogies between disease outbreaks and fires as they spread, and as you could sort of understand where they were and where they could be in the future. We really want to understand who's impacted, pretty obviously there. So that's been an evolving target, as many things have for coronavirus and the COVID-19 case. Certainly at first impacting lots of nursing homes, but now impacting a much broader cross-section of different populations in the US for sure. And then try to get, what I'll talk about today, try to get some understanding and context around how many will be impacted by the outbreak. How big could this become? And what can we do to mitigate and respond to it? So what can we do to prepare? What levers do we have to try to influence the outbreak? Because unlike the hurricane or the earthquake, in the case of a disease outbreak, our actions actually change the event itself. So in a contagious disease setting, whether you and I are on Zoom or come into contact in person, is going to change the likelihood that if I'm sick, I could spread the disease to you, obviously. So we have the ability to change the event in ways that we don't always in real time for other kinds of emergencies. But every disease is different. So we can't say we're going to have a response to diseases. Ebola obviously is very different than COVID-19, which is different than measles. So do we have vaccines for the disease? Do we have treatments for the disease? How is it spread? Those are all key factors, obviously, in how we understand it. And then that tells us what we have as options to mitigate it. So unfortunately, in the case of COVID being a novel disease, we don't have a vaccine. But something like flu, we could look at the vaccines we have for seasonal flu, for past strains, and try to mitigate with with the tools that we have in place. So what do we have? And unfortunately, in some cases, what do we not have? So we might have to take measures like we have with coronavirus and social distancing. So here, just really what is the role of predictive modeling? So how can we begin to understand these events? So I kind of hit on some of these already, but really breaking down how easily is the disease spread. So you may now, even in the news, folks will talk about the R value of a disease. So something highly contagious like measles, one person is likely to spread it to many other people. Some diseases far less contagious, and then something like COVID-19, somewhere in the middle. And how much does it take for you to be exposed to in order to contract the disease? So how virulent is it? And sort of how does it interact with the environment? So is it a zoonotic disease like coronavirus? Does it have more than one host potentially? Can it move between animals and humans, or do we have to have that concern for that in any given outbreak? Or is it a case where humans can only catch it from animals, or a case where humans are really spreading it to other humans? And how severe is the illness when people get sick? And really understand then how that transmission occurs. That's what we're trying to put into the model, right? What really matters. The contacts between people that live in the same house, that interact in a community, that travel from one country to another, or one region or one country to another. And then what do we think we can do about it? So are any of the people that we're trying to model who are impacted with this disease, do they have the ability to change their behavior? Are some people going to still need to go to work? Are some people going to be traveling that don't know they're sick, for example? So I just put a few of the, if you will, most popular approaches that we can apply to this. So we could try to understand, gather data in the world and apply statistics. So basically sort of fit the curve for what, based on what we know is happening in the world now, what might happen in the near future. Or we can try to understand really all the different groups in the population. So in a compartmental model, you're trying to really understand the individual transmission events in some way, ultimately through the math, really understanding how many people in society are susceptible, how many have already been exposed, and take them out of consideration. How many are getting infected at any given time, and how many have already recovered, and maybe you can hopefully presume they're immune from getting infected again. And then agent-based models, where you actually sort of try to physically understand, like sort of put the people into a box, if you will, like understand their engagements with one another, and actually sort of model the contacts they have with each other. So I'll talk about a project today, take a bit of a step back, where we try to bring this type of modeling together with a comprehensive analysis effort on the policies that are trying to interrupt the disease transmission for COVID. So in this case, we paired information we can get from the disease modeling with analysis that we can only get by going out into the world and seeing what sorts of policies are being put into place to try to change people's behavior and try to reduce spread by keeping these susceptible people away from these infectious people in some way. Or if they're going to come into contact, to reduce the likelihood that the disease will spread from those who aren't sick from those who are. And this basically, these are the compartments of the compartmental model. This is everybody who's not been sick yet is susceptible unless they've been vaccinated. In the case of COVID-19, we don't have that option yet. And each of those people can become exposed. So if they come into contact with someone who's sick, but that doesn't necessarily mean they'll get infected. So if both parties are wearing a mask, the likelihood of that transmission event occurring goes down, depending on how much viral load, how much virus the person who's sick is carrying around can influence that. How susceptible I happen to be as an individual to the amount of virus I get exposed to can change whether I'm infected. And then over time, we can track those who are no longer infectious to others because they've recovered. So that's the general approach. So I'm actually not a mathematician, so I work with others on the team to really flesh out the model and apply all the things that we need to consider. So I take on a lot of the public health piece or policy thinking piece, so we can understand sort of how simple can we keep the model while still capturing the core information. And in the case of the model that we built, we wanted to be sure that we considered once we learned how big a prominent role it plays in coronavirus COVID-19 transmission was people who are asymptomatic. So those that we wouldn't otherwise know are sick unless they receive a test. But we can estimate that they're, say, 30 or 40% of all the people that do get the disease won't show obvious symptoms or won't experience obvious symptoms. So all of these dots with all these states with the red dots are the people who are sick. So any susceptible person, as I say, can get exposed, and then we really want to track what about the asymptomatic people or those who are infected and might require hospitalization. So one of the assumptions of our models is that these asymptomatic people, they don't get sick enough to go to the hospital. So if we want to begin to understand some of the burdens that might occur on the healthcare system, we can model these infected people and try to understand, what fraction of those, based on our best available evidence, seem to need to go to the hospital at some point in their illness, and how many of those progress from just being admitted to needing to go into the ICU. And then sort of the model stops, sort of tracks those who've recovered and are now immune in our case. It's obviously still, as I'm sure you've heard, the duration and magnitude of that immunity for COVID is a big remaining question. But right now we just consider them immune for the purposes of our analysis. And then we track the proportion who will ultimately die from COVID in the modeled scenario. So some obvious things go into that, right? We need to go out into the world and try to get some evidence for how long people seem to stay sick in this case. So we apply this same sort of approach to well-characterized diseases to understand future outbreaks. So we know a lot more about the threat from pandemic flu. We know a lot more about measles. So we can apply this approach in many different contexts. But in COVID, that was in the early days a bit of a moving target. So we went out, like many other groups, try to get the best information we could, and we've evolved that over time and tried to better tailor it to the US in a lot of cases. So how long do people stay sick if they're infected? How long are they contagious, which is not the same thing in most cases? How likely are they to be hospitalized or to die? And we don't really capture this in the model, but it's certainly important as you do more of a deeper dive analysis to think about how susceptibility will differ for different populations, as well as sort of how likely is it to, as a sick person, to pass the disease on to someone else. Really, we're getting at this to help understand the intersection of where those policies and plans that are in place can help protect those who haven't been sick by reducing the likelihood of transmission. So I think I'll probably stop there before I go any further and just take some questions. I'll park on this picture of the model with a sense of the equations. But what can I help fill in there before I sort of shift gears and show how we think about this at the intersection with the policies that are in place?
Right. And in this case, everybody can unmute themselves. Think about a question that they'd ask. To give an example, I'll start and ask Justin to go back one slide.
Yeah.
And one more slide.
Mm-hmm.
Okay, in this, I'm going to put some numbers for Hawaii in here. It's like susceptible, we'd say 1.5 million, I guess. Are there any people that aren't susceptible in a population? So for this disease, have we already found some folks by nature or otherwise not susceptible? Then the next is how many are exposed. We've had various conditions of lockdown and etc. So it's not like an entire herd together. Infected with, in hospitalization, we've only had in Hawaii about 230 apparently hospitals, and ICU has been even a smaller number. those seem like really small numbers. And infected with mild or otherwise is over 5,000. But then the recovered is about half of that. And so the question is how come in 7 months we still have a very large population of those that have been diagnosed, are in some form of treatment, and yet apparently pose a danger of spreading. I'm putting some of these numbers in. The basic question that I'm looking for is, do you find a chart like this and then add some state or some region in the fashion that I was just displaying here to validate, and then make you wonder how to define the mathematical engines in each of those boxes?
Yeah. So I'll show some examples of how we have applied this to US states. Actually, I have Texas, but all of the model is public, so you could look at any state. So I probably wasn't super clear, so I can take a step back and say that this diagram represents all the states, but not exactly how we use it. So we run the model sort of in a progression over time. So we start with, say, an assumption that a certain number of people came from somewhere that had coronavirus and were sick, say in Hawaii at the start, and they are the first sick people that infect the rest of the potentially susceptible pool. So this chart really represents what the states any individual could be in at a given moment in time. But people will pass through that and we'll kind of run a counter and say how many are have reached this state now, and track that at different points in time so that we can see, if all things are equal and people still interact a lot and there's a few sick people, it'll exponentially grow until there's many sick people, and we'll see some examples of that. We know that people change their behavior and societies change the way that they function to reduce that. So I don't know if that addressed some of your question.
Yes, but I'm trying to get it specific to where Hawaii is and its decision process, but that may come a little later. If there's no other questions,
I do have a question.
Go ahead, Andy.
Andrew. So my question is, have you taken this model and applied it to more seasonal sub-epidemics that we encounter every year? For example, the flu season that we go through almost every year. And this is a general model, so you could apply this to any kind of disease that spreads. And so my question is, does the infection rates, are they much higher with the flu than they are in this when you apply this model to the current COVID-19? And if they're comparable, then that tells me that basically isolating doesn't really have much effect. I mean, I'm sort of on the trying to understand, is this really helping to stop the spread of the disease by this isolation? There are the questions I have regarding that is it actually effective, and do we actually create worse problems for ourselves by lowering the collective immunity by keeping ourselves isolated? Because by not exposing ourselves to the disease in smaller intensities, then we're actually not building immunity. That's the approach that Sweden applied, right? So they basically bucked the trend and decided, hey, we're not going to shut down our economy. We're not going to isolate people. We're going to build herd immunity, but we're just going to be a little bit more careful. And it seems like their approach, the numbers seem to bear that out. And we're not, I mean, like most of Europe and the rest of the world, we're basically just enforcing this isolation, where everyone has to stay at home and wear masks. So just your thoughts on that.
Yeah, so I think there's a few things I pick up from that. So one is that just comparing COVID-19 to a typical seasonal flu, it's many-fold more contagious and much more likely to kill you. So Generally speaking, yes, you're absolutely right. This is a framework you could apply to anything, and there certainly are some diseases that are more well understood. So measles is very highly contagious, but has pretty disproportionate effects on different populations. Also, in no small part to the fact that we have a really effective and widely used vaccine. We also, every flu season, have about half of Americans immunized for the seasonal flu. And we have a lot of, collectively as a society, past exposure to flu. So in the case of coronavirus, fully sort of having it spread through the population, these models support, and I think real world experience suggests that you can have really, really dire consequences in terms of total number of people infected in a very short time, that could overwhelm hospital systems, that could lead to lots of fatalities. So that's sort of what I could probably add most to that, is that
I would amplify what Andy just said, is in a herd circumstance and a low level density of the virus, if you're just walking around with a mask, you're not expelling. I'm presuming if you have some of the virus inside of you and it's a proper cloth mask, you'll go home with the whole quantity that you might have spread stuck in your mask. And hopefully if you disinfect it and wash it, you haven't been a part of the the environment endangering anyone else. And amplifying that, if your mask, if droplets are the most concerned element of spreading it, there's every reason to believe your well-designed cloth mask is absorbing and holding it. And if you're not sneezing, and it's probably a small quantity of even the high of level of drops that are coming out of mouth, and just closing your mouth and breathing through your nose would do a great deal of what we're expecting of a mask.
Yeah, and I would underscore that there's a clear separation between the question of, can societies have restrictive measures for a short time to drive down transmission, and then manage that risk in the long term by doing masking, reduced density, being cautious about mass gatherings. That's separate from, that doesn't require lots of people actually getting the full-blown infection and developing herd immunity. That's managing the risk of transmission, which is separate from putting all those people through illness that may have long-term consequences. So I see those as separate. So you can actually manage risk by stopping the transmission, and that's separate from actually having lots of people exposed. Does that make sense?
Hey, Justin, this is Joe. I have a question on the source of the data. What medical group do you get the data from, for as far as, how many people exposed and in the hospital and all that? What organization?
Yeah, so I'll talk a little bit about it now, and then two things is I can point you to the more detailed documentation on the website, as well as we can look at it a little bit in the model outputs themselves. But basically what we're looking at is we take the population sort of known by census, and then we are using numbers that are reported to state health departments in terms of cases to date or at certain points in the past. So that's based on testing in every state, reporting through hospitals, the various channels that you've heard about. And then we capture that because we're working to look at cases in every state. We use collated data sets. So like the New York Times has gone out to capture data from state health departments and other sources to estimate cases over time in every state. We use those data. The other parameters, sort of how likely transmission is to occur, and the asymptomatic and other sort of how likely someone is to transition to these other places, is a variety of sources, usually an average of different publications and publications collated by CDC, the sort of they reviewed and used in other national level models. So it's something we're constantly looking at because we know it's imperfect. And our goal really isn't to have precise answers for every bucket, but to begin to understand where the major drivers are and how we can link policy changes into this to begin to parse like what are the big levers and how many of these imperfect, but all the interventions we've got, we can stack up to try to make a difference. It's a little,
and how often do you update the database from the health departments?
so we do that every day. So New York Times releases an update every day and we pull in the latest data every day. One caveat is we're really looking at the cases there. So we haven't found a good source to date to get actual hospitalizations. So we estimate those from the number of cases rather than actual hospital counts that have been reported by states.
Okay, thanks.
Yeah. So maybe I'll.
Yeah, we can resume from where you were then.
Cool.
Justin.
So now this is all the things I think we've been talking about. So how do we understand now what actions can be taken? Obviously, much attention has come to many of these things, especially closing schools, these stay-at-home orders we've been talking about, masks and vaccines. So at the end of the day, though, all of these sit in governance frameworks, right? So there are 50 states and all the territories and the U.S. federal government and countries around the world all managing this pandemic, and their actions are interlinked, and their actions also have direct impacts on the people who live in the areas they govern. But we and many others notice that there's really a lack of connection between these different things and a lack of mechanisms to get all the information we can out of the policies. So in a collaborative project between Talus Analytics, the Georgetown University Center for Global Health Science and Security, a nonprofit organization called the Nuclear Threat Initiative, which also has a biological arm, which is the group within NTI that we worked with, and the Center for Global Development. We had a joint project on several fronts, including building out these modeling and this policy database and the linkages between them that I'll talk about now. So we set out to build this comprehensive data set, collect all the policies that we can, national level policies at a global scale, and policies for all 50 US states, and beginning to address territories as well as tribal nations in the data set. So we really want to capture a historic record so we can look at this in the future, understand what was the most powerful, what seemed to have the greatest effect. Also working with the legal group at Georgetown University to understand the authorities that may or may not underlie the different policies and to track court challenges to them. And as I said, sort of really to understand what works now and into the future. So it's called COVID AMP, AMP standing for Analysis and Mapping of Policies. I think we have about over 10,000 entries now. That's not quite 10,000, that's 10,000 policy elements. Sometimes a policy is more like 5 policies in one, and then we capture it in 5 entries into our data set. We capture about 50 different pieces of metadata, everything from where it applies, sort of the nature of it, like is it directed at restricting mass gatherings? Is it place restrictions on bars and restaurants? Is it about schools? All of those sorts of things, as well as the legal authorities. Is it an executive order? Is it an emergency declaration? When did it start? How long does it last? And we capture all the future, sort of the course of that policy. So if it's extended, we capture the new phase of its extension. Sometimes it changes, a lot of times it changes as it's extended, and then when it expires. And it's really designed to support this multiple different approaches. So linking to the epidemiology, the legal piece, and really geopolitical analysis. And it's all online at these links down in the lower right. So covid-local.org is the parent project and the AMP page, or you can also navigate to it from covidamp.org. And also importantly, like it captures the original PDF. So even as those documents may not persist on the internet or wherever we find them, sometimes it's Facebook or WeChat, capturing them and bringing them into a persistent data set that we manage. So this is what the interface looks like. You can go to the site and play around. I looked at Hawaii earlier today to refresh my memory. I will say that if you go there, you'll find it's out of date. So I apologize. The last entry of new policies was August 15th, which misses the latest pretty restrictive measures that I know have gone into place a few days ago. So this is an example for Texas, filtering down. So you can see the different kinds of things we capture, like is it addressing social distancing? You can look at different time windows. And here we've looked just specifically at Texas within the US. But as I mentioned, we also have countries around the world. We're working to build that. We don't have global coverage, far from global coverage so far, but we're adding countries all the time. So questions sort of about the motivation there. I can pause again. We have a lot of information.
I'll take a quick, in Italy, northeast of Italy, there was a small town that was basically a physical structure as a feudal area. And so that, but it's a long, well-defined community and family relations and so forth. Maybe 1,000, 2,000, 2,000 or 3,000 people. The Italian government surrounded it with troops and said nobody could go in and nobody could go out. And we will discover what policies are inside that town that are self-preservation. So it really turned out, I thought, to be a wonderful test bed if you consider they're all human guinea pigs. But I think they did it in such a way as to give every individual the best incentive to try to choose the most optimal safety regimes. When I heard of this, I thought that's an amazing opportunity for any analytics to be performed. Is it been in your purview to come across that and see it as a useful body of technology and information?
Yeah, I haven't looked at that. I haven't looked at that specific case, and I don't think anyone on the team has looked at that specific case. It would be interesting. We can see what we had in Italy. I know we collected policies there for sure. But maybe to the slightly larger point, you know, it's certainly not practical for a lot of places to have that kind of fence around, and it often doesn't take much for someone who does have coronavirus to like come to their family. Like there's lots of draws that can, when those systems fail, and you can sort of introduce it into a community that otherwise is not had to take tip-top precautions because they haven't been exposed, and then someone who has been exposed mixes in with that community. So, but yeah, certainly I'm sure there's lots of places around the world that have been able to sort of fence off and avoid it to date.
So this is Andrew again. Just as a corollary to what Phil was saying about Italy, it looks like you're focusing primarily on the U.S. and the territories in terms of your model. Is that a fair statement? You're not. Are you looking at how this is doing in other countries, or are you basically just focusing your efforts on guiding policymakers in the U.S.?
Yeah, that's a good question. So it's all evolving constantly. So we would like to do all the things all the time, but we prioritized it so that we first collected policies from around the U.S. because we knew time was of the essence to get all of those data in. Policies are changing very quickly, and we built up the model in parallel. So first we released the policy database, and then we built the capability to explore the epidemiological model and the policies together for the US at the state level. We very much want to expand the policy data set down to US counties or county equivalents. and we're actively extending the data set to countries around the world. We haven't adapted the model to really take into consideration all the different differences between countries that we may need to account for if we go to a global model. So sort of the current status.
I mean, this is really invaluable, the data you're collecting, but I would like to see. So right now, essentially in the U.S., we're all running under the same model in terms of how we fight the disease. But other countries, and for the most part, I think Europe and a lot of the other countries around the world are following similar models. But Sweden bucked that trend, and so I'd just be curious to know. Okay, if we took those different sets of policies and applied it to the models we're doing in the U.S. You know, is the outcome better or worse, or is it about the same? Because I don't know. I mean, it's a lot of like, you know, Sweden did a bad thing and they're actually going to pay the price later. And yet I'd like to see some hard facts of that matter, because if Sweden's approach and other countries like theirs are different and they've actually come out ahead, you know, that is something that I think we need to be aware of. And I don't think we're really looking into those alternate models, or even just doing it on a smaller scale where we just take a control, where we just take a county or a town where we apply a different set of policies to that town as opposed to others, and just see which works better. Because right now it's all pretty much across the board. So, you know, and our rates are, you know, our infection rates are going up. So, I mean, you know, I don't know. I think I'd like to see some alternate ways of addressing this.
So what you describe is exactly why we want to collect all the data now, and why we're collecting it alongside all of the reported case information. So it's exactly, the direction that we want to go to understand sort of the piece we won't always have a good sense of, or that we will need more elements to address, is you can make all the policies and plans that you want, but if people did not follow the letter of the intent, then there will be a disconnect. So we're looking at how in the coming months, and I think we'll be doing this for years, is exactly the type of analysis you're talking about, is that how did things play out in area A? What was the profile of their cases over time? What policies came on and off over that period? And how, using the data we can get, how did people actually behave? Do we have mobility information or some kind of data that can give us a bit of a sense of whether people really were locked down on lockdown? You know, what was the functional outcome?
In Hawaii,
this is Sam Gilly. Phil, if I can ask a question.
Sure.
Yeah, one of the things I was curious about is on New Zealand, and I think in Samoa, American Samoa, I think there's one of those islands that have no known infections, and basically because they closed down, I think. But they went 100 days without a case in New Zealand, and I was kind of curious because what's the difference between New Zealand and Hawaii? Because I was really surprised at how quickly Hawaii got infected, and I thought we had a pretty good system of quarantining people, and yet we did not have the success that New Zealand did. I don't know if you know the answer to that question, and I don't expect you to, but I guess maybe I'm just giving a comment more than anything.
Yeah, it's interesting, and I haven't looked into the specifics, but my impression is that New Zealand is not very densely populated, so that may be into their advantage, and certainly they've had some of the most restrictive policies. But yeah, that's an interesting point.
That's probably a helpful picture to show how the world's getting it. Thanks, Justin. We have 90 tracers hired, and I think we have another 20 on the way because of going to the outer islands. Have you done any of the analytics in terms of the mechanisms of tracings on a national level, we're spending billions of dollars. What what value has come out of that? I didn't notice that in your model.
Yeah. So in a couple of slides, remind me if I don't come back to it. I'll draw it, kind of close the loop on some of the metrics. So the short answer is we haven't done analytics on the contact tracing or the sort of cost benefit considerations or any of those things you're mostly touching on, if I'm following you. But we have, through the COVID local group, thought a lot about where that, where you can really engage contact tracing. And if you have many, many cases, it's not practical to trace all of the contacts, right? You are going to have to, most likely to contain that outbreak, have more stringent measures, just have people on their own stop, reduce their level of contact with each other. But if you have a very few number of cases, sort of going back to that, you don't need to pursue herd immunity to function as a society with a risk that you can mitigate. You can imagine a scenario where you get the cases down low, and then every time someone is sick, and they have very few contacts per day, you can then trace all of those contacts. So I know that many countries have been able to achieve more of that by starting from a lower number of cases, having trust and buy-in from the public to provide information to contact tracers, and a low level of contacts between people, so that they don't say, well, I don't even know the hundreds of people I've come into contact with today. They actually have a pretty short list of places and people they've had close contact with. So certainly contact tracing works in a certain context and is not a silver bullet if you have an enormous outbreak as a way to contain it.
Of the 200,000 cases that have been tested in Hawaii, only resulting in 5,000 plus confirmed cases, the rest were negative. How many of those cases were initiated because of contact tracing and saying, I think you might have it, we better test you? Or my own personal feeling is that I don't have confidence in where all these numbers are coming from and how useful they are in, for example, justifying the billions of dollars in contact tracing. If those individuals that are doing that tracing don't have the authority to say, you're at high risk, we're going to test it, we're going to now say, gee, I thought you were at high risk, but you don't have it. And that becomes a useful statistic of how the spread is actually working.
Yeah, so I'll definitely touch on some other metrics. I think there are ways, certainly we've thought a lot about with the COVID local group, and that other experts have developed different benchmarks, really to understand how you can put some numbers on, the percent positivity that you should strive for, that 5%, of tests coming less than 5% or less of tests coming back positive at any given point in time, sort of puts you in that ability to have people moving around and potentially contact trace where there is spread versus a bigger outbreak. But yeah, maybe we'll talk map first. Okay. So yeah, so this is the global map. What is showing here is in the orange circles, the new COVID-19 cases in the last 7 days. So this is those reported cases coming up in aggregate. In this case, we're using the Johns Hopkins collated data set of COVID cases. And so you can see some countries, the United States, this is an August 6th screenshot. So we had many new cases, growing outbreak in the US, growing in Brazil, growing in India. And then for the policies the countries where we have collected policy information, we have developed rules to either capture directly the policy. So if they have a direct lockdown policy, for example, in India, to annotate that. Italy was an interesting example. There's a mixture there. I think we've revised this now in recent days because they never really got rid of the lockdown policy, but they started to very much relax via other mechanisms. So functionally, they weren't in a lockdown by August 6th for sure. So we're learning all the time. We're developing rules for the cases where it's more mixed, like Italy, but we can still start to understand the context of the policies when you sum these all together. It's not like a lockdown anymore, or in the United States, really, where states are acting autonomously. So it doesn't really make any sense, and we've labeled them as the U.S. as a mixed setting because, California, Texas, New York at different points in its outbreak certainly were functioning differently, and we have the information to understand that. So here I got to the slide I was talking about. So in the following slides, I'll talk a little bit more about sort of those map views and places where we're analyzing the policies to understand what's the net sort of operating level of a state in the US or a country in the world right now, or at any given point in time in relation to their policies. Are they in this maximum social distancing or sort of lockdown state where people really are staying at home, thinking of, Wuhan and other parts of China or parts of northern Italy at different points in the outbreak? Or are they beginning to reopen, sort of like a stay-at-home type condition? So essential businesses are open, people are moving out of their house to get groceries, but businesses are really operating under telework type things. And then the COVID local frontline guide for decision makers and other products that we've participated in the development of try to provide some benchmarks so that local decision makers have a sense where the percent positivity may be conducive to operating like this. So here the 10% of cases positive, really looking at 3% test positivity rate. So that's out of all the tests you conduct in, say, a week, that you're seeing less than 3% positives. So I think to your question about Hawaii, I don't know a lot about what's going on there, but we know testing is not quite that simple. Not in many cases, not enough tests are being done in the US. There may be factors like, really when you're thinking of this test positivity, you're ideally hoping to have generally people in the public getting tested, even though they don't think they're sick, because that's where you're going to catch the asymptomatic people who may still be spreading COVID. But in a lot of cases, the guidance doesn't even support that. So it's complex in terms of who's getting tested, how many tests are available, how long it takes for those test results to come back. So there is lots of factors at play, but I would encourage you, happy to talk after, or you can check out the guide. But throughout this, we're trying to marry up the framework where we can look at these phases, understand the types of policies that generally underlie them, and connect that back to these kind of epidemiological benchmarks and case numbers that we can model or measure over time. So details in here, you can certainly see this all on the website, but I put 2 slides in here to drive home. In some cases, it's straightforward to understand the intent of the policy. Italy, this part of Italy is on a lockdown. But in other cases, we really need to go to a whole set of policymaking to understand the net effect. So there might be a place that doesn't have a stay-at-home order issued by the, for example, US state, but they may have all the looks like a duck, quacks like a duck that we've identified that go into those type of policies, like they've closed the schools, they've closed non-essential businesses in the private sector, and they've limited mass gatherings. So we look for that across the policies that we have in the database. And that's through the tagging when they're entered by the researchers. And we do the same type of procedure for safer at home, and even for what's now the tag we have for most of the US, which is new normal, which really there are not a lot of restrictions. I know there's parts of Hawaii right now certainly are the exception, but in many parts of the US, there's not a lot of restrictions left, except at the very sort of end of the spectrum. So in addition to the sort of maps that I showed in blue, if you're interested in specific types of policy, you can dive in detail. So each of the different sort of policy types is also available from the options menu on the map. And then you can see for any given country at any given time, whether or not they have a policy of that type in effect. So this is some, in Brazil, there's at least some policy making that's been made to address supporting hospitals, basically, versus, enforcement measures versus core social distancing policies, limiting mass gatherings and things like that. And then I was going to talk through a bit more detail in the US. We've talked about a lot of this, but we get down to the US, to the state level in the US, and really want to provide that profile over time. So this is for August 6th. You can see any given state. Again, we're really getting to be pretty at the light blue end of the scale in terms of what we're seeing come through in the policies, and with schools opening in many places, I think that's reflected in sort of how we're seeing states open up. But back on August 6th, there were at least some states with some additional restrictions apparently in place. So it's more fun if you go to the site. You can choose the different types of policies, all this information for different policy types, like it is available for countries around the world. You can really take a much deeper dive in the US at the state level. We have thousands of different policies in the US, but also bring it back up and just play through the US. And we could probably just pull the site up at the end if we still have time. But here, this is looking at May 1st. You see much more dark blue. States were under much more strict measures, as I'm sure you're experienced. But by the time we get to, or we go back to April 29th, even more restrictive. But as we get through to August, lots of light blue again. So you can actually play through and slide the slider and explore on the live site. The last piece are just like bring back the model together with the policies. That's the whole goal of this. So taking Texas as an example, on August 6th, not very many restrictive policies in place. We have them showing here in the new normal phase, despite the fact that in the last 7 days, we're seeing a lot of new cases, not across all of Texas, but really, I think still across many parts of Texas.
Excuse me, Justin. If we could, we've come to the end of the meeting or close to it. If you have one or two slides, I'd like them to go to our closing.
Yeah, absolutely. So this is just, you can see all this online. You can understand sort of the course of the outbreak in the context of the different policy phases. So very restrictive orders in the beginning, least restrictive orders later. You can click on them and view the policies themselves. And then you can sort of do the what if scenario. So you can go in and you can say, actually, tomorrow I want to put a stay-at-home back in place and watch the modeled effects on cases drop in the future. And then the last one here, just we also include just if there was no change in behavior, no change in policies, how bad could it have gotten for context in the green. That's pretty much all I have. Just we've talked about many of the things that models don't do. So I hope that between the policy analysis and the models, we're helping really drive understanding and provide new context and information to decision makers. But you always have to have some input into the model to run it. You have to accept some assumptions and know that it will allow you to make decisions that will make a difference. That's what I have.
Thank you, Justin. And when you close your screen, I'm going to come up with one more screen for you.
Okay, let me see. Stop here.
And here I go. And then we'll have a little chance after the screen comes up to, as soon as it allows me to do that, which is here, and which is here, which is here, which is here, and which is, so Dr. Justin Kerr, we thank you, and we would like to present you with the Certificate of Appreciation. Normally we get a picture together and we hand this to you, but this one is going to come in the US mail.
Understood, thank you.
You're welcome. And I'm going to stop sharing now. The official program is over, but we're leaving the field open if there's some questions or some folks that like to go to the group share. And whoops. And you can leave. I would like everyone to put their picture on in this instance, as we're in this mode. Andy with his Hawaiian swinging tree in the background.
I have a question. This is Sam. How many people does it take to input all of this data? Do you have a crew of 50 people or 10 people or what?
That's a good question. So the core entry of the policies has probably been about 15 to 20 at a time. There's a staff of research assistants or undergraduate students at Georgetown University who do much of the core policy data entry. And then there's a team of several lawyers who do the additional data that relates to sort of authority and underlying laws that relate to the policymaking. And then there's on our side, like structuring the data, updating the site. There's several of us on the team that do that. So I mean, in all, the whole AMP and COVID local team across the several nonprofits and companies is probably more on the size of the 50, but really entering the data has been that 15 to 25 research assistants doing a lot of it.
Is ERIS the engine, the software engine that's behind this, or some proprietary software that you have?
So all of the everything, all the sort of infrastructure we've built out custom. So the web interface itself is all built by us custom, and then we use some off-the-shelf tools on the back end to capture the data. But yeah, pretty much all homemade infrastructure.
Is it Johns Hopkins or CDC? Who's your main link to hand off timely data?
So in terms of use, anyone can use the site. In terms of bringing in the data, on the case data side, we use the data collated through New York Times and data collated through Johns Hopkins. But in terms of users, we have sort of many thousands of folks visit the site since we've had it up, which is pretty neat, and from all different countries around the world and states across the US. So,
follow up to that, Justin, are state governments using your site?
Yes, that's certainly an understanding. We have had conversations with a few different states who have been looking at it in different contexts, and some other groups like in the public and private sector. But really, we don't know everyone that's using it. Only if they kind of reach out to us and have a question, or if we engage with them some other way, do we know for sure that they're using it.
I just tried the model. I ran through Hawaii, and maybe I didn't put the stuff in right, but it probably didn't put in right because it had 1,000 deaths by November 6th for Hawaii.
Hey, great. Just to remind everyone, I'm going to have to leave. I don't know if this will continue to run if I close this. Yeah.
I think if you have to leave, we probably have to close. And it's been great to have you all here. Joe, I would wish you put your portrait up there for our speaker to see who he's been talking to. And Sam, I think you've been up a picture-wise.
I gotta get a camera.
Oh, okay. And Joe? That doesn't look like the person I remember, but if you put yourself
it's
up
my
there.
new look.
Anyway, Justin, that was very good presentation. I really appreciate it.
Yeah, really good. Thank you.
Thank you so much, Justin. It was great. Really very informative.
Great.
Looking forward to future events like this. So it was great talking with everyone, and hope to connect again soon. Take care. Bye.
Okay. Bye.
Bye.
Bye.